So this is the kind of scene that you'll see in focal segmental glomerulosclerosis on the schematic. So a segment of the filter is scarred and abnormal. And the rest of it has the fused foot processes here, but it otherwise is preserved. And then on the biopsy, this is what you'll see. You know, in the actual, this is an actual kidney biopsy. So you can see here there are segments of the glomerulus that have scarring. But here's one without. So, you know, and I picked an area for this picture that had a lot of it. So elsewhere on this biopsy, there were filters that looked fine. So this is FSGS on a regular biopsy. And out here, all this stuff, these are the tubules. So filter, 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 tubules. Okay? So I'm not going to address this much at all, but to tell you, so what gets this all started? Well, probably one of the things is a problem in the immune system, plus some other changes that leads to a change in glomerular permeability for proteins, and then you lose many crucial proteins, you know, one of which is albumin, which leads to the swelling problem. But I have to tell you that other things happen to you when you have nephrotic syndrome too, be it minimal change disease or FSGS. You know about this top one. The other thing that can happen is you can lose a protein, which is a small protein and is lost in quantity, called antithrombin 3. And in your body you have a system of clotting, anti-clotting that's going on in your blood vessels all the time that kind of regulates when you're bleeding and you need to clot, when you've got a clot form there that you don't need anymore and it needs to be lysed and go away. So you have this constantly internally regulated clotting, anti-clotting system going on. And when you're nephrotic, the clotting, anti-clotting system gets screwed up. And because you lose an important part of it, part of the screw up is that you lose an important part of it called antithrombin 3, so you tend to clot more. And patients who are in the throes of nephrotic syndrome tend to clot, and one complication of being in the status of being nephrotic. When you're treated and you're in remission, the protein's gone out of your urine, this goes back to normal. But so you can get deep vein thrombosis, you know, clots in the blood vessels in your legs that can cause you all sorts of problems. And where that clot, if it breaks loose, you know, it can go through and cause clotting in your lungs too, and you can throw a pulmonary embolus. That's a clot that's thrown into the lungs. Vitamin D binding protein is another important protein that's lost in the urine, and vitamin D binding protein binds the precursor chemical to activated vitamin D. So vitamin D has to be activated to work, and that 25-hydroxycholecalciferol, which is the precursor, is carried around on vitamin D binding protein. So if you lose your vitamin D binding protein, you lose your precursor too. And if you stay very nephrotic, another result can be that you get bone disease akin to rickets. Another bad problem that's part of the infection risk problem in nephrotic syndrome is that IgG can be lost in the urine. Plus, there may be some problem in making it in being nephrotic. And then IgG is the main gamma globulin that fights infection. That this level of less than 100 is terribly low, and means you don't have any functional of the important gamma globulin IgG. So infection is a major risk. And a place that is, you know, just ripe for infection is this belly full of fluid. I mean, that fluid is warm, it's got some sugar in it, protein in it, and it's great food for bacteria. The same fluid in the tissues. If you get a tissue infection, that's cellulitis. That's more common in nephrotic syndrome. So another bad problem. You can also get hypothyroidism with nephrotic syndrome because thyroid binding globulin, which binds to thyroid hormone, is lost in the urine too. And then there are important other proteins, particularly immune system proteins, that are affected by nephrotic syndrome. So one thing that patients who have active nephrotic syndrome need to be really aware of is that they're setups for severe infection. And they have fever. They, especially in the face of swelling, you know, don't wait an hour, don't wait a day, call your doctor now. And if you think you're very sick, just go to the ER. Because this fluid in the abdomen, like I said, is great medium for bacterial growth. And there are some particularly bacteria that have a special capsule that seems to be harder to be fought in the face of nephrotic syndrome, called pneumococcus and E. coli. And there is a shot for pneumococcal infections that can help make you less susceptible, but it may not help you as much in the face of nephrotic syndrome because what it does is it boosts your antibody levels, but if your antibodies are all leaving you, then it's obviously not going to be that helpful. So infection is a bad problem. So the mainstay then is if you've got nephrotic syndrome, we want to get rid of it, get you out of the nephrotic state. If you have minimal change disease and you have the easy childhood kind, then often if you get prednisone, 2 milligrams per kilo body weight for a month, and then it's tapered from there, you'll get rid of your episode of nephrotic syndrome. You may have recurrent episodes, but usually that initial episode and subsequent episodes will respond and go away. If you keep having episodes in spite of being treated with prednisone, so you're treated with prednisone and then either as it's tapered or right after it's stopped, you have another episode, then you definitely need a biopsy to see is this minimal change disease or is it focal sclerosis or something else, and then consider other drugs, including Cytoxan, chlorambucil. And I group cyclosporin and Prograf together. I just wrote cyclosporin down here, but the actions are similar in this situation of cyclosporin and of Prograf, and they can both be used. It's been used the last couple of years, or cyclosporin or Prograf are the big choices there. When you do a biopsy in somebody with nephrotic syndrome, and the little kid in the older child or adult who has nephrotic syndrome, when do you do a biopsy? When you first meet them. They need a biopsy right away. But if I have a 5-year-old who comes to me with nephrotic syndrome and everything looks like typical minimal change disease, I'm going to initially treat that child, see what happens, and then if it doesn't go well, I'll do a biopsy. So if the child doesn't respond to prednisone, or if I can't get them off prednisone, or if there's something that makes me think that they've got what I call nephritis, they've got blood in the urine and signs of more extensive kidney disease when I first see them, or they're older, I'm going to do a biopsy right away. This age of 10 years old that I put down, that varies from nephrologist to nephrologist what the cut point is to do that biopsy because of age. But, it's not that big a deal. If the cut point is 8 or 9 or 10, somewhere in there, the child needs a biopsy if things aren't going well. So I think that's mostly what I wanted to tell you about nephrotic syndrome. That